Well, look at this, Renee. We're podcasting, but I'm coming to you from a remote location. Let's just go with that.
Right? I mean, this has been a wild month or so, so we've had a little bit discombobulated everybody. Things are happening in life. Jason's traveling to two new contracts across the country. I've had some family issues on my side, and so we've had a hard time even getting in the same place at the same time. So it's fairly impressive we're all together today. But today, everybody, before we're going to talk about on the ground impact series, we're finishing up our series. It's been a 4-point series, and we had a overview at the beginning, so 5 weeks in a row. And this last week, we're talking about the no wrong door concept, which is actually one of the more favorite parts of this whole series. But let me just remind you what we have talked about to get to here, and then we'll chat about what's happening on the farm. But to get to here today, we talked about 4 pieces. So if you remember, Jason and Brent traveled all over the state of Iowa, 3,500 miles, I don't know, 49, 50 plus meetings around the state.
Yeah.
And around the country, they've been to 15 states last year. So this on the ground series is like, what did we see on the ground that we have, the themes that are across the country that are still the same. So we've talked about the barriers to the system. We've talked about care collaboration issues. We talked about system change without pain is my favorite one that we've done so far. But today is no wrong door possible. And I'm really excited to kick this off. But before we do that, Jason, since you're out and about, what's going on the farm while you're out and about today?
Well, next year we'll have to add. I was in two Canadian provinces this month or last month, or I don't even know when month that was, Renee, but we'll have to add to the list of places we've been.
Right.
It's still on recovery from tax season, so there's still some things I'm working out. So that's really what's happening on the farm. That's April, and it's just a lot of questions and back and forth and recovery from the process.
Yeah, I can hear that. I got my own recovery systems going on over here. So today we're going to talk about no wrong door. And let's just give a background of what the heck no wrong door means. But the concept in behavioral health, and we're going to question the concept today, everyone, so be prepared. But the general gist is that every door should be the right door, and that people should be able to go in anywhere and be able to go and get the help that they need for behavioral health. But we've been on this track now, I don't know, 15 years, 20 years. And we're beginning to think that maybe that's backwards, right, Jason? I mean, maybe
Yeah,
maybe this whole
yeah,
idea is not quite the way this everything laid out to be. Because what we're going to tell you, here's our premise today, everybody. Not every door is the right door.
that's
And I
correct.
don't think that's ever changing. Do you, Jason?
No, no, there will
So
always
let's
be
talk
some wrong
about the
doors.
doors that
Yeah,
you have gone into that were absolutely the wrong doors.
yeah.
Let's kind of start there, but maybe before we even get to that, that's part of the story time, but maybe we should talk about what was the concept behind this? This idea of no wrong door. What was it? What's it supposed to be? And why have we worked so hard at trying to find something that has been so elusive?
Well, and we have to remember there's been pockets of innovation where the no wrong door approach has benefited people in care. Especially in IDD and other areas. We've seen a lot of work done over the last 20 years of really fulfilling what no wrong door is. And what is no wrong door? It's coordinated entry, it's reduced navigation burden, person centered, it's broader access, meaning all income levels, all abilities, and it's improved efficiency, which I can get behind all of those things, Renee, because I
Absolutely.
think all of those create good systems, right?
Right. So the concept, everybody, is you're supposed to be able to, if you're a person who has behavioral health needs, go to a door, and the door would be a medical door. So it's all the whole concept of no wrong door already. You're not going to Target. It's not working there. But you're trying to go to a medical door and that you get your help. It's kind of a one-stop shop kind of idea. Or you get pointed in at least the right direction. People know when you ask for something, how to get you to that place, right? And the goals of this concept are good, right? The goals are coordinated entry so that you're coordinated so you only have to tell the story once. That's one. What else, Jason? What are some of the key points of this that are supposed to be good about no door, no
Well,
wrong door?
it shortens that gap between asking for help and receiving the right help for the right identified issue,
Right.
right? So you're not
Yep.
bouncing around from physical location to physical location. It's supposed to decrease that gap in when people don't get care, in which they generally just fall off and never come back to
Right.
get the right type of care, right? I mean, it's pretty simple. The more we can organize the system to move someone to the right place from point A to point B, the more likely they are to follow through and get better.
Right. And so you're supposed to also really reduce that whole burden of navigating, right, the system.
Right.
Because if you can get to a door that's, quote, the right door, then they're supposed to tell you what's next. And you're supposed to have this plan. And it's supposed to be person centered, where it's around your
Right.
issue that you came today for. And they can say, okay, here's the next steps at these places. And you don't have to go, oh, this wasn't the right place. Where's the next place I should go? Because to your point, people fall off at that point. If you're in a spot where you're not doing well mentally and you have the courage and the wherewithal to get to a place and then they cannot help you at that place, the odds of you making it to the second place drop off significantly, and for sure the third place. You're just like, no one can help me becomes the mindset very quickly, because you're like, I went, I asked for help, they didn't help me, nobody can help me, even if it wasn't the right place. So the concepts are really good, and it's supposed to be more efficient. I mean, really, truly, it's supposed to be more efficient. So that's what it's supposed to do. But why doesn't it work, Jason? Why in rural communities this doesn't work at all? And so why does it not work?
Well, because we still struggle with warm handoffs when it's
Yeah.
coming from physical health care to behavioral health care, or generally across the board, right? We don't see that happening, and so a lot of times in rural communities, if we go see, even if we go to emergency department, they don't know who the local specialists are, especially for substance use and mental health disorders, unless it's an acute situation. If it's an acute or crisis situation, generally it's pretty limited. But just to help someone get to the right place, it doesn't happen. And Renee, are we going to talk about resource guides? Because you know how I feel about resource guides. And I have been in two different communities, actually three now, in the last 3 weeks, where, and just let me just set the stage here. I think it's great when people go out and collect what's happening in their local communities. However, when you have competing groups going out and developing these resource guides because they got funding from a grant over here, and then the state paid someone else to do it over here, and then you end up with these gigantic lists. And so I'm on a project right now where we're supposed to vet the resources of a local rural community to put in our training, which seems simple, right? And so I opened the resource guide that was state funded to a local nonprofit. And I'm like, well, let's see what the crisis number is. And so I'm in a state that I haven't done a lot of work in. And I open it at the crisis section. There's 12 numbers, 12 different phone numbers, and it says crisis. No further delineation. So I'm going to do a training, and I'm going to train people who are supposed to be getting better at noticing things happening in their neighbors and coworkers. And I'm going to say, here's 12 different numbers. I'm not sure which ones you should have them call
You're going to have
if
to
they're
call
not.
them and figure out what happens when you call them.
So I'm going to have to narrow it down myself. So my question being, was that resource guide helpful to the general public? Did it help guide us to where we need to be? And did it help reduce barriers to accessing care? Or was it just phone number vomit on a website that now has a great QR code that is now, when I go places and say, hey, what resources are here locally? They're like, didn't you read the guide? Okay.
Mm. Well, I would love to tell you this only happens in behavioral health, but let me tell you about the guide that we have for reentering from prison.
Oh,
So
please.
the state did not even make the guide. Random guy, everybody
Oh,
knows his first name. I can't recall it off the top of my head. Started making a guide because it wasn't said guide, and it was for all the community districts across the state of Iowa. And he listed all the places that you could get all kinds of help and supports. And my most important part for us was the piece of where people could go, like the actual live there part. But there's other parts. Exactly what you just said. Exactly what you just said. So what we ended up having to do was go district to district across the state and take them this piece of paper and hand it to them and say, okay, do you actually use these
okay.
things in this guide? And a lot of people are like, where'd you get this? What's this list? And then they'd start out with, well, we don't refer people to this one anymore for such and such reasons. And oh, well,
Yes.
we can't send people to this one for such and such reasons. Oh, but there's these other ones that just opened and none of those are on this list. And da 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 da. Da. So it starts exactly like that. So then you've got this list, and as soon as you make a list, everyone, it's outdated the day you do it. Because sometimes especially in nonprofit support world, it's the program is as good as its leadership or the staff that happened to be there in that moment. And so they lose a key employee, they lose the key person. And in some small communities, it is the one ARNP that is in the town, right? They lose that person for whatever reason. And then it's still there that it exists, but it doesn't really because the
So
psychiatrist left, the
so
whatever.
what's the solution, Renee? What's the solution that our state came up with and many states have come up with to fix this? It's to hire someone and call them a system navigator who can come and help you to read the resource guide and maybe guide you if you can get a hold of the system navigator. I know I like the concept of system navigators, but I think as you can see in our conversation here, look how convoluted this has become. Because now we have to have a position for someone to interpret the resource guide because
Well,
no
I
one can
know
figure it out.
in a state that we're really close to, the system navigators, the way that really works is there's an online chat feature. So as somebody calls
Yes.
in to the system navigator, they just do
Yeah.
online chat with all said other navigators throughout the
Yeah.
state who might also know more information than the said
Yeah.
navigator that you just
Yeah.
called. And if they're all live online at the time, you might get the answer you're looking for. But then, because there's so many gaps, they started this other list. The other list is things we cannot find in the system while
Right.
navigating, and they're just tracking it for data purposes to see what things we cannot find. I can tell you things you cannot find because they're all the things that we need for people to use in our system. So it's like I don't know, Jason. It just continues. I thought the word you were going to say was dashboard, and I was just going to have a fit
Oh,
over here because I thought you were going to tell me we're going
I,
to put all these resources
I,
into a dashboard. And let me just tell
the,
you, if I get one more dashboard, all y'all out there talking about dashboards, just stop. Just stop. Dashboards are only as good as the data you put in. It doesn't matter how flashy it is, doesn't matter how cute the little signs are and the little just all of it. The pictures you can pull out of it and the graphs and the charts, bunch of baloney. If the data going in is bad, it's just bad. So stop making a dashboard. Nobody needs another dashboard. We didn't need them in car dashboards aren't exciting. Your tech dashboards aren't either. So stop that for all mankind. Sorry about that
so
little rant, but I
I
thought you were
think the
going to say
takeaway,
dashboard, and I was going to
no,
be like, "Oh, for heaven's sakes," because that's supposed to tell me how to resource access stuff. And you and I, we just,
yeah,
when you were in Arizona, and the dashboard where it had all the acronyms, and we couldn't even find all the
yeah,
acronyms, and you got to the bottom of the dashboard, and you
I
couldn't even
love that.
understand the dashboard. Remember that one? Those
Yep.
things just are everywhere, and so it's like that also isn't easy. Yes, the printed page isn't good, but shoving all the printed information into something online, if you're never going to touch it to update it, also not useful. So how
So
does
we
this
can
tie
do
back to
better.
no wrong door? I mean,
What we
we've
could, we
gone
have
off
to do
about this list,
better. I mean, I think this tells us how important a no wrong door is, right?
right?
And where is it that people can go? And we have to do better than this resource guide, system navigator. All of these things just really cover up the real root issue. And that's we have an access issue. We have an accessibility issue, especially when it comes to behavioral health and substance use disorders. And so, what can we do to deal with the root issue instead of just adding all these layers on top of it? And we just add layer upon layer upon layer. And then people get upset when you question them and say, hey, I don't think that actually is helping us navigate. And the person who spent the last 6 months putting together that resource guide gets very angry and slams their fist on the table in front of you. Not that that's happened recently, twice. But that's what happens when you question the status quo we have. And Renee, I don't like going with just the status quo because I think we can do better across the board of how we do this, right? And so when we think about solutions and moving forward, what should that door look like? There's some doors, you're right, we shouldn't use, but what are the doors that people should walk through and have a reasonable expectation they're going to get connected to the right care at the right intensity at the right time?
When I think of this, Jason, this you're gonna be thrown off at first, but it makes a lot of sense. People who design sidewalks.
Oh,
So if you're on a campus, there's always those worn paths that people actually walk between
right.
buildings. And
Yep.
that's the path people are going to use, whether you put sidewalks there or not. You can put
True.
all these fancy sidewalks, all these places where you prefer people to go. But there's actually a path that people really use that is rarely actually got a sidewalk on it. But the people are showing you by its use that that is the path, that is the navigation, that is the system, that is the place that people want to walk. Same is true in mental health. People go to certain places. That should be the door. That should be
Yep.
the door. That's where people show up. We know where those are. Emergency rooms in rural departments. We know that that's where it is. They show up at jail where they shouldn't. They
Yep.
might show up at a crisis center where they shouldn't. I mean, there's places. So those are the doors. Don't make these fancy doors no wrong door that nobody ever thinks to go to. You put all these resources to make everybody a door when they have no business being one because nobody's coming there. So why? Why? But you see it all the time in design, just in
Yep.
sidewalks. Streets, sidewalks are really, really good at that. The collective mind, the bright, brilliant people are like, people should go this way. So we're going to build it to go this way. People don't.
Right.
They go the way they think they should go, and that's where the path should be. And so when we're doing this no wrong door, how many resources are we wasting trying to make people show up at doors that they were never going to in the first place?
W- We even label them. We call them diversion programs. We're like putting the chains up across the corners of those sidewalks to try to, and people are climbing over them. Right. So when are we just going to say, you know what? It's time that we just recognize that the front door is the emergency department of our rural hospitals.
That's right.
And we need to co locate and have our behavioral health crisis services and outpatient services there at the times they need them to be, period. Figure out how to make it happen because that's where it needs to be, because that's where the people go. We don't have to like it, but that's what it is. And that's where you're going to make the greatest impact on your community,
Right.
period.
So you think about the University of Iowa Hospital, they put their diversion program right next to
Right.
their ED. That's
Right.
been the most successful model so far
Yep.
because people are coming
Absolutely.
to the hospital and surprise to many of you who might not pay attention to federal law, EMTALA, which I can't tell you the acronym, but it's emergency medical something or other, where basically the law is if they land on your property, you're going to care for them if you're a hospital.
Right.
They're going to hit your property. So to have the diversion right there makes so much sense because you're legally, federally responsible to take care for them. So maybe that ED door isn't the actual place they should be so that you can, once they hit the ED, though, you take them and move them. So then they're
Right.
still cared for on your property, on your ground. You're following the law and you're diverting. Makes way more sense than to putting some other diversion someplace else that's a car ride, a sheriff's ride away that nobody's going to go naturally. It doesn't make sense. And your sheriffs and deputies, once we did the crisis centers, one of the things they said, because part of the crisis centers, you have to be cleared medically
Right.
by an emergency room. If you're not medically cleared, you can't be at that level of care. They're like, that's not my job. And they're not wrong.
Mhm.
It's not the
Right.
sheriff's job to know that somebody's medically cleared to be dropped off here or here. They just need them to go to a place. So that again, the hospital is the place that can clear them medically to put them in crisis. But we
And
didn't do it like that. We tried to put places
we-
out in the great
right.
beyond that nobody's going. And then we have empty beds and beds shut down. And people are like, well, we had so many subacute beds. And like, yeah, but you had 5 people referred total for the whole 12
Right.
weeks, right? So it's like we're trying to build things to force people into spaces they don't go. And then we don't have the resources and the money for that anymore. We just don't.
No.
So this whole thing is just messed up. So you were going to talk about some other things that have worked a little bit better. Do you have some data or some thoughts you wanted about like how this is going? Because I mean, that's like decades of us shoving people in the wrong door, and it's like this isn't working. So when are we going to like be able to figure this out? Like, what is going on out there?
Well, I think if we look at what, the LTSS system, and we're going to have some stuff in the show notes if you want to kind of dive into this a little deeper, they've made a lot of headway, kind of like I talked about earlier, in this episode. Like this has worked to some extent in a lot of places. And I think the opportunity now as we shift to rural is really thinking about how do we create true crisis response centers that meet people's needs. And I love you talked about the sidewalks and think about design. I went into a local critical access hospital here recently, and walking next to me was a guy in an orange jumpsuit in shackles going to the ED. And we all go in the same front door, which is fine. I had no problem with that, right? He had to be medically cleared, just like you spoke of. But, that image can be off putting to some folks or someone who's already in crisis, seeing a whole bunch of law enforcement dragging a guy in an orange jumpsuit may not be as trauma informed as we like, right? So how can we create other entrances? A lot of this has to do with design and thinking about how do we use the spaces we already have in our communities more effectively. And that means broadening the definition of who should be there and who gets served there. Hospitals already have to serve everyone, especially critical access hospitals. Let's help them with the tools to be more effective doing that. And then we actually get to see them move the needle on community health and the social determinants of health, and those social drivers of health. That's what we're doing this for. We're talking with multiple hospitals across multiple states right now about what are you doing when it comes to social drivers of health. What does your needs assessment say? And how are you actionably acting upon this? And right now, I can tell you, we have three hospitals in three different states, and they're all complaining about the same thing. And they're all lacking the engagements. Like I used to think, oh, this is just a one off. Like everything must be more functional in this. And the farther I travel and the wider we get away from home, we're like, no, this is just how messed up our healthcare system is across the entire country. And that may be cynical right now. I might be cynical. It's really early in the morning here. There's a time zone difference. So I might be thrown off a little bit.
Not enough peppermint mocha, everyone. His brain's not fully clicking yet today. So when you're thinking about, I mean, again, that's no wrong door. I mean, I know I keep hammering on this, but the other thing that happens when you try to break off doors, what you just mentioned about folks in shackles, right? Is try to make like doors for those people and different doors for these people. That doesn't work either. It just doesn't work either. And so it's like, you're trying to funnel people
Right.
and here's where it comes down to. People designed all this stuff and didn't ask the people who use the services what they wanted.
Mhm.
They weren't at the table. We
Yep.
talk about peer support 1,000 times over and how they should be at the table and driving the system and meeting people in the hospitals and having these conversations. We still to this day don't do that. And we have workforce issues. We won't use peers. It's insane because a peer meeting you at the emergency department who knows that they don't really need to be in the emergency department would be the fastest person to get them out of the emergency department and diverted elsewhere because they could say, hey, I was here and I needed this, and this is what I think you could use too, and we could help you do that, but it's not going to really be here that you get this. We need you to be over here. And they could just walk them to the right place and move on. But we
Mhm.
don't ask them. It's like the higher ups are like, well, I really don't want them in my door here. So I'm going to
Right.
make this other door here for these people, and they should all go to this right door, and we're going to call it that. It's not how it works. And it's like, if the system, I mean, and I know we all in behavioral health want it to be like the Pollyanna, the way we wish healthcare worked. But to your point, it doesn't work in those ways, right? So it's broken. So let's meet it where it is. The system is
Yep.
working the way it is, and the ED is the place. So let's build it there. I go back to what the governor is talking about related to cancer and how she wants the hub and spoke type operations across
Mhm.
our state where people can go in and get all their tests in one spot.
Mhm.
That is not a wrong idea. And I know it's just for cancer, but the same thing would apply. You just put this next to
Yeah.
that cancer center because guess what? When people find out they have cancer, they often have a mental health type crisis that goes with that because
Right.
it's very jarring to your system.
Yep.
Just lost my dad to cancer. It is
Mhm.
not good for him, not good for any of us that were involved in that, right? So there's mental
Mhm.
health issues related to cancer. Put it together. Put it
Yep.
together. Because I'm telling you, when you find out you have a chronic illness, there's a mental component to that. So what are we doing building something different? Don't do that. Just put it
Right.
right where the person's going to need help. And if it's not them, it's the family who's dealing with the person who has the issue, right? So it's
Right.
like co-location is so, so important naturally where the person's going. So if they're going to be more likely to get cancer testing, pair it with that. If they're going to be more likely to get their prenatal care because they're pregnant, pair it with that. If they're going to be more likely to go to get their flu shot, put it there. If they're going to go to the pharmacy, put it there. Like where the people go. And I know it just people get frustrated because they want the system to do XYZ, but that isn't the system we have. So let's like stop trying to shove behavioral health someplace else and try to shove people to it. It doesn't work. It just doesn't work. And we've been doing this for decades now. So this whole no wrong door, there's absolutely wrong doors. So before we go though, Jason, can you tell me some of the stories of doors that you've met? And maybe this will throw you off, but name a door without telling the name of the company, but the story of a door that you're like, nope, you shouldn't go here. You got any of
Oh my
those?
goodness, you're putting me on the spot.
Oh, I have one
Um,
to, I have one to kick you off.
Kick it
So there
off.
was a
Well, I
small
think.
hospital up north, I won't say where, that we told the staff at that hospital said, if my kid
Yeah,
had a
it's
mental
true.
health issue, I would
Yep.
not bring them here. And it was a hospital. And they'd go, I would go to the hospital over there. the next county because they can handle mental health. I would never bring my own child. I work here, but I would never bring my own kid here. That's an example of not a right door. You could be a hospital with a door, but you would not be the right door because that hospital did not do the services that were needed in that particular case. And unfortunately, the staff knew I would never bring my kid here. I would take my kid there.
Right.
We hear that everywhere, everywhere.
I mean, I hear it all the time. It's hard to identify one place.
Yes,
And
there's
I
so
mean,
many.
kind of when you were talking, I thought about, I thought about jails because so many jails don't even give medications or
No,
have very basic, they don't have counselors or therapists or
no,
psychiatrists to manage the really high need. I mean, I remember a jail we went to, and it was the most horrific thing I've ever seen. When we
it's
walked
still in
through, it
there.
was a huge jail. I've seen some stuff, but let me tell you something. We were with a group of legislators and we got to go where people don't generally get to go. And we saw things inside that jail that no one should have to be incarcerated in those types of conditions. And it wasn't that they weren't trying to take good care of folks. These were just such sick people in the wrong place without access to what was needed. And it was the state's responsibility to do
Yeah,
something. And it was heartbreaking. I mean,
yeah,
so we see the extremes of where people end up in the wrong place and no one knows what to do. And then there's just that decision fatigue within our system of being frozen because we don't have the capacity at a systems level sometimes to deal with things. And we see that at a high level all the way down to the local communities. And I think about, I was in a meeting where they told me how great and robust the resource guide was. I left that meeting and went to lunch with the mayor, and the mayor leans over to me and says, you know, my son had an issue. I had no idea who to call. I didn't know what the local resources were. He was the mayor, he knew businesses, and he had lived in the same community for 50 years, 60 years, 70 years. And that to me summarizes where we're at with not being able to use the resources that maybe are available, but not in a way that's usable for the general population. Because we may know they exist back in the back of our head, but when we need them, are we able to actually consume that information and act upon it? And generally, when we're in crisis or we're dealing with a loved one who's in crisis, we don't have capacity to go through a list of 20 different crisis numbers and figure out which one is the right crisis for me to call at this moment. And
no,
every day, Renee, every day.
every day. Yeah, I think too, maybe the whole idea of making every door supposedly a right door, we made them all wrong. I mean, it's just like instead of like naming, because 988, eventually the idea is there's one number, one place, one call. And I think we're going to have to get to that in this system too. It's like this
Guess
is the
what?
door, the
It's
one
not even
door.
in the resource guide. 988's not in the resource guide where I'm
Why
at.
would it be? You don't even know
Why
where
would
it
it
goes
be?
if you called it over there. You don't telling where it went. I mean that's just
Hey,
awful, but it is. It's rough. It's just everybody. We've been doing this for decades, and no wrong door approach
I'm
is not working.
I'm gonna leave you with one thing, and that's
Yeah,
don't assume we can just go in one direction because how we communicate is important. And you
yeah,
know what I do every morning when I get here? I go to the breakfast, go down to breakfast at the hotel in the lobby. I read the newspaper, Renee. There's a physical local newspaper. I
nice,
have learned so much by reading, and I've read the comics. Like I look forward to it in the
nice.
morning, and I realized people consume information differently in different areas, right? We think putting it
Yes,
out on Facebook, then
yes,
everyone should just know. Well, a lot of people don't necessarily go to Facebook or Instagram or TikTok or whatever it is, right? And suddenly I'm going back to, boy, it sure was nice when I could pick it up and read it. And I learned about an assist training coming up. I learned about a peer support program for women. And I'm like, where'd I learn this? It wasn't electronically. I learned
yes,
about it in the old school daily newspaper that comes out. And so we may need to rethink that sometimes we have assumptions about how people consume information, but maybe we should challenge those assumptions sometimes.
yeah. I think we did, and it goes back to when we talk about cascading messages. We've talked about in previous episodes about how you say it and where you say it and how many times you say it. Just because it's one resource guide posted in one place does not make it the message.
And I think we're going to put this podcast out on VCR tapes. I think we could put this out on VHS. and we'll send it to people. We could mail it to people, kind of like a rental thing. Has this ever been done before? Is that something that we could
I threw
do?
away some brand new VHS tapes, so I'm sorry. I think
Renee,
those already went away before you requested the VHS tape. So,
this
but
is
don't
a
worry,
business
I
model
have
idea.
DVD options for you, and I've got small cassette options, and
We
probably
could mail those
there's
out.
probably more
We,
VHS I just don't know about. So don't worry, I have options for you.
yeah, okay, sounds good.
Options. So today, everybody, before we go, it's Recovering Politician Self-Care Policy of the Week. And this is going to be an interesting one for you, but we're going to take some time off. Some things have happened here with me and Jason that the next 3 weeks we're going to take this time off. There's going to be a wonderful series for you on the podcast
Um,
related to workforce. And so we're excited that we've already recorded these, but we've put them together in a way that you can understand it better. Jason's going to do the intro for those, but we're going to take a little bit of time off here to get a few things taken care of in life. But that is a self-care policy. Sometimes you just have to stop a minute, and we're in one of those seasons. So we're going to take a little break. Jason's going to be traveling all over the place. He has another trip to Puerto Rico coming up. So he's going to be all over the place. And I've got some other things to handle, but we'll be back. Don't worry. Just a couple weeks, we'll be back with a brand new series. So don't bug out on us the next 3 weeks. The next three are really good. They're actually some of our better ones that we've done before, but we're going to put them together in a package all about workforce. So if you've been struggling on workforce, please join us then. But today we talked about no wrong door approach, and we're really tired of this approach because it doesn't work. And we're two decades, both of us 3 decades into this, and we know for sure it doesn't work. But we keep working on it because somebody tells us we should. And maybe the challenge today is to think maybe, just maybe, we should pitch this concept and start again and go where the people actually go. So hopefully you enjoyed that conversation. Before you go today, please don't forget to follow us on LinkedIn, Facebook, or YouTube. And if you leave us a positive review, we'll send you a prize. Thanks, everybody. Have a great day. We'll see you soon.